So I'm going to tell you, it is a theory. So that's the reason the title says compensatory theory. So the title, the original in the program says around knee, but I think with HTO I can try to prove my point and say that what I believe in, and then we can have a chat or discussion if somebody disagrees, which I'm hoping probably most of you will do. So I'm going to give you an alternate theory, or the theory behind that, what happens when you do an osteotomy. And is there anything else you can do? And I'll give you a proposition to hopefully, which you might not agree. Well, hopefully you'll agree. So what's a day-to-day problem? And a young patient, osteoarthritis, middle compartment osteoarthritis, this is what happens. This is a common day-to-day problem. If you look at the weight bearing, how it goes, and the ground reaction force, so from the spine, it goes through the hip and then go to the ankle, and then your weight bearing axis is from the center of the hip to the center of the knee, center of the ankle, and your ground reaction force comes around the similar point, but is slightly lateral on the ankle. And the reason for that is, if you see, your calcaneum is slightly lateral to the talus, with no angulation. So if you see the vector is between the two. So your ankle, the ground reaction force is slightly lateral as compared to the center, because the calcaneum is lateral. So because the weight has to go through the calcaneum, through that. So this is your vector, which you will get in your standing or walking. So other thing is that, so medial compartment osteoarthritis is an intra-articular problem, yeah? Which means the tibia is normal. And what we're trying to do is, we're trying to high tibial osteotomy. So we are correcting the intra-articular problem, extra-articular in the bone, which basically means we are intentionally deforming tibia and creating a deformity. Because tibia is normal. The problem is intra-articular. So what we're doing is, we're using osteotomy rule 3. Because we are angulating the tibia, right? So there is some residual translation. So if you see this same X-ray, if you see this way we want to correct, and if you correct it by pure angulation, right? Because your osteotomy is, so if you see, your apex of the deformity is there, but your osteotomy, we do it down, we can't do it there. So when you do the osteotomy there, this is what happens. Now it may be quite small, but there is a residual translation deformity. It doesn't matter in our day-to-day clinical practice, but we're using osteotomy rule 3 to correct an intra-articular problem. So in a conventional HTO, which we're doing the plating, what we do is, you have this leg, so let's do an osteotomy. So this is the leg, this is where the osteotomy. So what happens is that when you do osteotomy, it moves out. We do a lateral, we are opening wedge, so leg is lateralized, right? But the problem is, nobody walks with the leg out. Because if you have a deformity, nobody walks like this. We all compensate somewhere to actually come, because if you remember a weight-bearing axis and ground, so weight-bearing axis is a plumb line, right? And your ground reaction force has to go some way. So it can't go laterally. So it has to come straight. So what it does is, we have to compensate somewhere, right? So something must give in to get it straight, right? So either you can have hip adduction, and there is a possibility, then some suggestion that hip adduction forces changes a little bit, but there's not very much data out of it. But there's very little, if any. But what happens is the hind foot which actually corrects. So if you look at because ankle, there's a very little give way because the ligaments. So what happens is that hind foot is quite mobile. So you put a tibia in one way, hind foot has to compensate in the opposite direction. So if you look at the compensations, in a varus deformity, there's an eversion compensation because hind foot will go into valgus and you have correction. So your axis is straight. Similarly, in a valgus deformity, the hind foot goes into varus and compensates. Because inversion is more than eversion, so we can compensate valgus deformity a lot more than the varus deformity. And if we overcome, if the subtalar is fixed or the deformity is more, then the foot compensates by either pronation or supination, depending on the direction of the deformity, to get the foot flat so you can walk normally. Now, what other thing can happen with the deformity? So if we suppose this is a normal hind foot, right? This patient has a middle compartment OA. If you do, if there's a deformity, then what happens is that hind foot had to compensate, right? Now, it may not compensate. You may not have to do 30 degrees opening wedge in the knee, at the knee, but whatever is deformity will compensate. What that means is the movement arm will increase. When the movement arm increases, the surface area, so the shear goes up, which means they are more prone to the osteoarthritis. And so we did a systematic review looking all the data available on the compensation. And when we looked at it, we found that if you look at the talar tilt, so these are conventional HTOs done by plate, right? So if you do pre-op and post-op, the position of the talus. So talar tilt, pre-op is in varus, right? And then comes to neutral. If it is a varus, it goes towards neutral. And then is a hind foot is valgus and it is neutralized. So the tibia is in varus, the hind foot is in valgus pre-op, and as the tibia goes that way, all thing comes towards neutral. And what happens is that, so Choi looked at the data specifically in the subtalar joint. And what he reported is, there's the hind foot alignment view. If you see the angle increase, it changes, but the movement arm changes as well. If you see where the axis goes, it is medial to the calcaneum here. So your axis. So actually, so what happens is that there is a compensation, okay? Following compensation, what do we do? So how do we assess it? That is because if he is looking for something, we need to be in a position to check it and assess it. So standard X-rays we take. But the problem with the standard X-rays is, this is a study published that if you take the hind foot X-rays with the foot pointing neutral, 10 degrees internal and 10 degrees external, your angle is actually quite different. Which means, unless your X-rays are taken properly, you can't assess the hind foot properly, which is another problem. And it changes significantly depending on how the rotation is. So a problem is, we don't have an ideal thing to take the X-ray. EOS probably, or a standing CT is the good way, but we don't have a standing CT. There's also a possibility that minor compensations, the minor problems can be easily compensated by the body. Because it's always difficult to assess these minor problems as well. The other thing is about the knee obliquity, which we talked about, so I won't go into much more detail. So we don't know how it works, because one of the ideas about the knee surgery, HTOs, is that we need to maintain the joint line. And I think a two-level surgery is increasing in a lot of, getting more and more popularity. And there's a very good result what you showed, Matt. And I think idea is to keep the knee joint parallel to the ground. But how much it is, which we discussed in the talk this morning, Ahmed showed that. But we don't know exactly, but we don't want to do it too far off. Long-term outcomes, they're pretty good, as Matt showed a number of studies. But the problem with all of them is, in none of the studies, nobody has actually looked at the hind foot. There's no mention. Now, I have to say, I didn't look through systematic review and I didn't do hundreds of search. But what I did in the limited search, I could not find any mention of a hind foot post-HTO. So, if you look at this case, so it is the same X-ray which we showed earlier. So this is where we want to correct it. That's our apex of the deformity. So you bring osteotomy down, you do that. The problem with this conventional osteotomy is that you will have a valgus malalignment of the limb, which means hind foot will compensate. If you do a translation mainly osteotomy, so rather than angulation alone, you do translation mainly plus a bit of angulation, then what happens is that your axis is still there, but there is less risk of a hind foot compensation because hind foot has not gone into that, your leg has not gone into that much deformity as the angulation osteotomy alone. So bit of a translation, mainly translation, bit of angulation will minimize your risk of hind foot compensation. The other problem is that all the knee surgeons I know of, none of them look at hind foot or ask the question, how's your ankle subtalar? Some might do, I'm not saying they're 100%, but most of them don't ask, examine, or x-ray hind foot before the HTO. And the problem is, if your patient comes to foot and ankle with a hind foot pain, nobody looks at the knee either. We all are equally responsible in a way that we are so focused in our own specialty, we are so blinded, and that we don't see anything else. We just focus on a specialty. So if there is a problem with HTO, if there is a problem, it will come late, and B, it will go to foot and ankle surgeon who wouldn't see the knee surgeon, so very hard to correlate that actually what happened. Because there are two different specialties happening at two different times. And this is the point Matt mentioned earlier, that it is the long-term follow-up which is important, because unless you know the long-term outcomes, you don't know whether the thing is right or wrong. So therefore, my proposal is, if there is a previous hind foot problems with the fractures, osteoarthritis, if there is a pain, right? And and if you do angulation osteotomy alone in any of these situations, then what will happen is that you can unmask a problem. And something which is pain-free may become painful. It may not happen immediately. It may happen 1, 2, 3, 4, 5, 10 years down the line when you have a problem. So therefore, the proposition is, what I propose is, that every HTO preoperatively should have a foot and ankle assessment. And if correction is small, hind foot is fine, we can have a angulation alone osteotomy. However, if there's any history of hind foot problems, pain, or any concern on your examination can be worrying or is a potential problem, patient should go translation mainly and a bit of angulation translation osteotomy. So to summarize, it's a theory, it's not proven. We are looking into it, we're trying to work out, and we're getting multiple failures, funding, a lot of issues coming around, gait analysis, all the kind of things. Hopefully we might come around with a mathematical formula finally with finite element, but I don't know whether it will happen or not, because we're still working on it. There is some evidence that compensation happens, right? We can't for certain say what is the effect. Long-term results are not clear, and I believe if there's no evidence, doesn't mean it doesn't happen. It may not happen, but we don't know. So therefore, if there's no evidence, then we should look logically and treat and make our decisions logically based on what we understand. Thank you very much.